All right, thank you, John. Hopefully you guys can all hear me. Same thing like John said, if I see nods, and I hope you guys can hear me. But like he said, today we're gonna go ahead and talk about some medications. I try to make this as interactive as possible. So if you guys have questions or comments as I go, feel free to either unmute and just interrupt me, or if you feel more comfortable, throw it in the chat box. I also have my email address towards the end, I believe, of the presentation. And you guys, if you think of questions later, if there's something unrelated that you want to ask about medications, feel free to send me an email. Just as a disclaimer, I do work some for Gator Care. So if you guys have any problems getting meds, questions about copays, things like that, I can definitely assist with those as well. All right, and we are going to go ahead and get started. All right. So as I said before, today we're going to talk about medication management of diabetes. John will probably send out these slides once I send them to him. So you guys will get them after the presentation if there's anything that you want to look at later. So big things, how to manage diabetes. I know you guys have done a lot of this thus far in the classes. Of course, it's not one thing alone that fixes what goes on with diabetes, but it's a combination of all of these things. So of course, a proper diet and physical activity, usually, kind of strenuous exercise a few days a week. Weight management. This has been more of a hot topic if you watch the news or if you've heard about some of the new diabetes drugs. But even the ADA, or the American Diabetes Association, is really now emphasizing the importance of weight loss, and they're now saying up to 15% of body weight for patients that are qualified to lose weight. Proper sleep, easier said than done, I think, for most people, myself included, but really we're kind of learning more and more about the effects of proper sleep on our bodies, actually resting, decreasing stress, things like that. Really has a huge impact on chronic diseases such as diabetes. And then, of course, what I'm here to talk about is medication management. So like I said, meds should be used in combination with all of these things. No treatment is going to be 100% effective if you don't do a little bit of all of these strategies. And I'm sure you guys have talked a little bit about treatment goals and A1C goals, but just a reminder once again, our A1C goals for most non-pregnant patients or adults is going to be around less than 7%, with the caveat that patients don't have significant hypoglycemia. So diabetes treatment options. There's a few different ways you can kind of group treatment options for diabetes. Usually the easiest is just to say, is it something oral that we take by mouth, or is it some of the newer injectable agents or insulin? So oral agents tend to be sometimes some of our older drugs. They are usually first-line agents because they're easier to use, and as I said, they can be less expensive. Injectable agents, these are drugs that you obviously inject, usually subcutaneously. And the big thing here is that these are not insulins. So we have two types of drugs in this class. So your GLP-1 agonists, and then a newer drug that is a GLP-1 agonist and a GIP agonist. And then last but never least, we of course always have insulin. So insulin is a whole topic within itself. I don't want to get too much into it today because it can be a little overwhelming. Remember that insulin is used for all type 1 diabetics because it's essentially just replacing what should be in the body but is not being made. There are some type 2 diabetics that are on insulin as well. Usually that's determined by your baseline A1C. If your A1C gets over 10, the guidelines usually do recommend that those patients wind up on insulin. I think a big thing to keep in mind is that being on insulin is not a failure. A lot of people think like, oh, I tried the other meds, they didn't work, and I wound up on insulin. Not necessarily that you did anything wrong. It might just be kind of a combination of different factors. But insulin is nice in that it is basically replicating the most natural process. So it's just replacing what should be happening naturally in the body. We have different types of insulin. Like I said, I won't go too in depth with any of this. But if anyone here is on insulin or just more curious about it, I have taught insulin classes for patients. I used to make them inject themselves for practice just with saline. Obviously, you guys don't have to do that because you're on Zoom. So I guess one benefit of Zoom, but kind of an interesting topic. And like I said, if you guys have any questions, feel free to reach out about any of this. So I gave you a bunch of different meds. So then how is treatment decided? And I'm sure we've all gone to the doctor before, and you tell them a bunch of info, and then all of a sudden they throw back some recommendation or some drug that they're going to treat you with. So how exactly do they come up with that decision? So one of the big things is they look at the guidelines that I mentioned earlier. So the American Diabetes Association, or the ADA, they publish yearly guidelines, and it's called Standards of Care in Diabetes. If anyone's really interested, you can just Google it. It's free to read. It is a little long and can get a little not very interesting at times, but there is some really great information in there and some great tables. And they go through everything. So they talk about goals of A1C, they talk about glucose monitoring, continuous glucose monitors, preventing complications. Of course, they talk about picking treatment options. So they really give like a very comprehensive overview of how to take care of patients that have diabetes and all the things that you should be looking at. So once we think about what do the guidelines recommend, other things that we of course have to consider are affordability, right? A drug is great to prescribe, but if you can't pay for it, it's not going to do you a whole lot of benefit just sitting at the pharmacy. So drugs are only as good as our ability to pay for them and for us to get them on a regular basis. We do have some strategies if you guys are having problems affording drugs. A lot of the newer agents have copay savings cards from the manufacturer. Some of the older drugs you can get free actually at places like Publix and I believe Winn-Dixie or Harvey's. You can get a little creative. So if you guys have any problems with that, I'm always up for the challenge to help figure that out. Of course, other things we consider is prevention of adverse events or side effects. I mean, I think we all can say we've taken a medication once and felt terrible from it. You don't want to keep taking that medication, right? So how do we give patients things that are going to help them, but also don't make them feel bad in the long run? And then, of course, patient preference. So you'd be surprised. Some patients say, I hate taking things by mouth. I'm never going to remember to take it routinely. I'd rather take something that's injectable once a week. So everyone's different. Everyone has their different preferences, things that work best for them. Some people that work outside are not going to want to take insulin if they can avoid it because they don't want it to get hot. So just little things like that, you always have to take into consideration when you're helping a patient pick the best drugs for them. And really just to show you guys how helpful these guidelines are. So this is a little overwhelming. I think we could all agree. And there's not going to be a quiz on this in the end, don't worry. But this is a screenshot of the general drug recommendations from the American Diabetes Association. So you can see there's lots of different things that go into the decision-making practice that your provider has when they're deciding what to treat you with. So if you start kind of up here in the, I guess, bright green towards the left, you can see that they're really focusing now a lot on cardiovascular and renal risk reduction. So preventing those long-term cardiovascular side effects, such as heart attacks, strokes, heart failure, and then also helping to decrease the risk of renal impairment. So they talk about if you've had heart failure, which would be this red section in the middle. If you have CKD, which is chronic kidney disease, it's this, I guess we'll call it tan section kind of towards the right. And then if you do have cardiovascular disease, it's this, I guess, blue-gray, we'll call it, towards the left as well. So that kind of all can help guide treatment recommendations. And then you can see as we move over to the right, it's for patients that maybe don't have their target glucose achieved with the options of the left, other agents that you can add on. Like I said before, they do now really stress the importance of weight management and weight loss for applicable patients, and kind of stratify by how much weight some of these agents help patients lose. And then, of course, at the very top, I think this is, we'll call it navy, they say none of this should be used by itself, right? Lifestyle modifications, educating yourself about diabetes. You guys have already done that. You're here today. And then, of course, like looking at social determinants of health, so affordability, preferences, things like that. So really cool. The guidelines are full of charts like this. Like I said, I know they're a little overwhelming, but really helpful to kind of know like, hey, maybe this is why my provider picked what they did, or, you know, they didn't completely make something up. This is usually what they're going off of. Okay, so with that, we will start talking about our meds. So first we're going to go over some of the oral agents. I really only included the most common oral agents for the treatment of diabetes. There's a few that I left out that are either older or just not used very often. So if anything that you guys are on or have taken in the past that you might have a question about is not included, like I said before, feel free to ask. So we are going to start where most patients start with their diabetes treatment, and that is metformin. So anyone, I can see you guys in the corner, anyone heard of metformin or taken it? You can just raise your hand if you want. Yep, so I see some nods and some hands. Metformin, in the history of drugs, it's an older drug. So I believe it was approved in the 60s. I'm not saying anything from the 60s is old, but this is an older drug. But the great thing about metformin is we love it. It works really well. It's reliable. It is like your old car that you can just trust forever and you know it's never going to stop working. We really consider metformin to be our first line agent for the treatment of diabetes because we have so much data about how effective it is. So the way that metformin works is it decreases glucose that is made in the liver. So our liver constantly makes this low level of glucose, which was really helpful thousands of years ago when we didn't have constant supply to food. We don't need that now. You know, there's a Chick-fil-A and a Chipotle on every corner. So to help kind of shut off that constant release of glucose from the liver, metformin just turns that off. In addition, metformin also decreases absorption of glucose through the GI tract. So when you eat, you don't absorb as much glucose as you normally would. In addition, metformin can also help to increase insulin sensitivity. So basically, how well do your muscle cells respond to insulin? So we know over time, what happens in type 2 diabetes is that patients develop insulin resistance. This basically helps to decrease that. So things to know. How much did metformin lower your A1C? This is one of our most, I guess, beneficial drugs, especially when you think about bang for your buck. So metformin can decrease your A1C by up to 2%. So pretty good amount. Of course, it is a little bit dependent on what dose you're on, but most providers will kind of slowly increase your dose as you start to tolerate it. Cost, we love free things, we love inexpensive things. Metformin is both of those. I know for a while it was given away free at Publix, I believe it was. And I believe this one is also cheap at Winn-Dixie. If not, it is still very inexpensive, just because it's an older drug. How to take, kind of depends on how well you tolerate it. I'm sure some of the people that have said they've taken it or heard of it before have heard of some of the side effects. That got a lot of nods. Okay. Not the most well-tolerated drug at first. a lot of GI side effects, nausea, cramping, some diarrhea. But it does work so well that we really encourage patients, if they can stick with it, to kind of try to get past those first 2 to 3 weeks. After that point, most patients tolerate this drug pretty well. It can also cause some weight loss, usually about 5 to 10%. So kind of an added bonus there. And even has some literature showing that maybe it helps to prevent things like breast cancer. There was some discussion about whether or not it helped increase mortality in COVID patients. I don't think anything ever really came of that, but a really great drug and very beneficial for patients.
Rachel,
Yes.
I have a question.
Yes.
I know the side effects here, but I've heard different stories and stuff and different things, but is there any long-term side effects with the metformin after you've been on it for a long time or whatever?
Not very common, no.
Okay.
And that's a great like benefit of anytime you're taking a drug that people have taken for a long time, is that we know there's not a lot of long-term side effects. Really, like there is a potential drug interaction with contrast, but not really a side effect. Besides that, long-term, there's nothing to look out for.
Okay.
So this is like a drug that I feel is very safe. Besides the GI intolerance, if you can kind of get past that, it's relatively smooth sailing from there.
Okay, thank you.
Yeah, that's always like a great question for metformin or for any drug. What are the long-term side effects? Because you have to think, when a drug gets approved by the FDA, that drug company has only submitted 3 to 5 years worth of data to the FDA. So we don't know what happens 5, 10, 20 years down the road. And there's been not a ton, but there's been quite a few times that drugs have been released to market. And then 5 years later, we realized, oh gosh, if you take this for a while, there are long-term side effects. I don't know if anyone here remembers like Vioxx from the 90s was similar to ibuprofen. Patients started dying of heart attacks. Actos and Avandia are 2 diabetes drugs that were pulled from the market, or just Avandia, excuse me, because of those long-term side effects. So any drug that tends to be older, we usually know more about the risk of long-term side effects. Some of these newer ones that we'll talk about in a few slides, I don't have as good of an answer for you, unfortunately, but that's just because they haven't been around very long. But no, the first few that we'll talk about, like I said, in terms of drug lifespan, are pretty old. And I feel like they're all relatively safe. Everything has a side effect or a risk, but these are pretty minimal. Thank you. Then we'll go to our next class, also an older class of drugs. These are called sulfonylureas. But the most common 3 are the 3 G names on the left. So glipizide, glyburide, and glimepiride. Hopefully you guys have heard of some of these. Also pretty first-line agents. Super inexpensive as well because they are all generic. And the way that they work is they basically just squeeze whatever insulin is in the pancreas out. So great drugs if you maybe get hyperglycemic, especially around mealtime, because it helps to kind of like squeeze out more insulin and then control whatever glucose you ingested with that meal or potentially with that snack. Not great drugs if you don't eat consistently, right? So anytime that we're increasing insulin in the body, we want to make sure that we're not getting too low. So if you're someone that doesn't always eat, maybe breakfast or lunch, or you just eat kind of sporadically, not the best agents. But if you're pretty reliable in your meal and food intake, like I said, older drugs, safe, and pretty inexpensive. A1C lowering, once again, up to 2%. So pretty effective, especially when we talk about costs. They can be, $2, $3, $4, I think, a prescription. How to take kind of depends on which of the specific agents you're on, but usually once to twice a day, and before you eat. So usually take the medication, and then eat probably like 30 to 60 minutes later. Additional notes, like I said before, older drugs and can be good at rapidly lowering glucose levels because they do just help with that insulin release in the body. Okay, moving on. So next we are going to talk about what used to be a new class of oral diabetes drugs, but is now starting to phase out a little bit. So these are drugs called DPP-4 inhibitors. I think the most commonly known drug in this class is Januvia, which is sitagliptin. There are 3 others, the alogliptin, linagliptin, and saxagliptin. They all work relatively the same, and really there's no benefit to one over the other, except for, which one is the most affordable, which one your insurance covers. So the way that these drugs work is they work similar to some other medications we'll talk about briefly, but they work by helping to prevent the breakdown of 2 hormones in our body. So these hormones are called GLP-1 and GIP. And what these hormones do is they basically help digest food. So by preventing the breakdown of these 2 hormones, what winds up happening is we have decreased gastric emptying, meaning basically food is in the GI tract longer and moves slower. So you don't get those big spikes of glucose after you eat. And then you also tend to stay fuller feeling longer, right? So you don't feel hunger again in 2 hours because that food is probably still slowly moving through your GI tract. So patients tend to lose weight because they're eating less and they're getting a more controlled release of glucose from the food they eat. They also help to increase insulin secretion from the pancreas. So they do a few different things, but pretty great drugs. We use them inpatient as well because they're not really associated with any side effects. Very well tolerated. I think the main side effect that they saw in the clinical trials with these medications was nasopharyngitis. So just kind of like a stuffy nose, but it was pretty short-lived. Kind of weird. Don't really know the why behind that, but something to remember, I guess. They are not our most effective drugs. They can increase A1C anywhere from 0.5 to 0.8%, usually a little bit closer to that 0.8%. But they are relatively inexpensive. Most of them are generic now and once daily. So not a lot of bad things to say here, right? Not, super expensive, well tolerated. You just take them once a day. So for a lot of patients, these are a great oral option to add on that works very easily for them. And then second to last of our oral drugs are SGLT2 inhibitors. So if anyone on the call ever watches like the nightly news or any of the primetime TV, you always see commercials for these drugs. They're like a big push right now from drug manufacturers. And these are drugs called Jardiance. I think is the most commonly known one. I think there's a commercial out there right now with people like singing and happy about taking Jardiance. But these are newer drugs and they're really cool because they work in a completely different way than any other diabetes drugs work. So the way that they work is purely within the kidneys. So normally our kidneys start to excrete glucose when our serum glucose is around 180 to 200. These drugs work basically just to help increase that urinary excretion of glucose. So it drops that threshold to around 150. So once you get to that that level, your body will just start spilling glucose into the urine and basically gets rid of glucose an extra way. So kind of cool. So yeah, Invokana, Farxiga, and Jardiance. I think there's one other one that was just approved but isn't on the market yet. But like I said, if you watch the news, I know you'll see commercials for these. They work fairly well at lowering A1C, once again, around 0.5 to 0.7%. Unfortunately, they are expensive. They're all brand only. They're new probably within the past 5 years, and only taken once a day. But a really cool thing about these medications, I don't know if anyone on the call works in cardiology at all, is that they have great data. So these drugs now work for patients to help prevent kidney disease. So it's been shown to prevent or slow the rate of progression to patients having kidney impairment, decrease need for dialysis, and also improves cardiovascular outcomes. So these drugs actually can be used outside of even having diabetes. If you are a patient with heart failure, these drugs have been shown to improve mortality. These are like the hot drugs right now in the medical field because they have so many benefits. So lots of things that you'll hear about these. I actually just got an email, I believe it was yesterday, that you can use them in more heart failure patients to help improve outcomes and reduce death. So really cool. You'll probably hear more and more about these drugs. Probably would have been great to buy some stock in a few years ago, but really great data coming out about them. So the big side effects are not super common. There's an increased risk of infection, usually like a urinary tract infection, or potentially yeast infections. Remember, anytime you have glucose, bacteria love to gobble up glucose. So more glucose in the urine can predispose patients to that. There is a slight risk of increased amputations, not really well explained, and it tends to be in patients that are really prone to diabetic foot infections. So if that is you, this might not be the best option. But really, besides that, we are trying to get a lot of patients on these drugs. Like I said, we use them irrespective of whether or not someone even has diabetes now for heart failure patients. Most of those patients are on empagliflozin because of the great outcomes. So something to consider. Talk to your physician, see if one of these could be right for you. Not the best A1C lowering, but their benefit is really in those long-term benefits, preventing heart attacks, strokes, and renal impairment. And then last but not least for oral drugs is going to be a newer medication within the past 2 years, I believe, called Rybelsus. This also has a very catchy commercial, like with a little song that I won't sing for you guys, but it is basically oral Ozempic, which I'm sure everyone here has heard of. Very hot topic right now. And the way that these drugs work is basically, once again, just to decrease gastric emptying and therefore food ingestion or intake. They also decrease glucagon or glucose secretion from the liver, and then increase insulin secretion from the pancreas. This drug is a little beneficial, I guess, over the other GLP-1s, and that it's oral. A lot of people don't like injectables. So this is a similar, benefit, just a different route of administration. A1C lowering anywhere from 0.5 to 1.5%. So pretty effective. But the caveat is that it is expensive. So it's brand only. Most of the time, insurance companies are going to want you to fail other drugs first, or have tried other things without getting an appropriate response. It is only once daily, which is nice, but it does have a lot of side effects similar to metformin. So nausea, fullness, diarrhea, which, obviously helps with the weight loss. But, you don't want to be too miserable, of course. There is also some warnings from the drug manufacturer about some more serious concerns. So acute pancreatitis, which most diabetic patients are already predisposed to, gallbladder disease. If anyone's ever had that, it's not fun. And then also potentially a risk of thyroid cancer. This was mainly seen in rats, but still something just to be aware of. If you personally have had thyroid cancer or a family history, I would probably vote to avoid these drugs. And that takes us to the injectable GLP-1 agonists. So very hot topic right now, because these drugs are being used very often for weight loss. We have a bunch of different options. Semaglutide, which is Ozempic, and Wegovy is the kind of like the forerunner of the group right now because of the beneficial weight loss that it's shown. Really some great outcomes. There's other options such as exenatide, I believe was the first of this class to be released. That was Byetta, if anyone remembers that. A few moons ago, I think I was in pharmacy school, so probably around 2010, that was kind of the hot drug. Bydureon, similar, it's just once a week, but they all work the same. So once again, decrease gastric emptying and how much patients eat. Basically, you feel fuller longer, and then also increase insulin secretion. So same A1C lowering, 0.5 to 1.5%. Just the big difference here is that it's injectable versus oral. Some of these are generic. I believe the exenatide's generic now, but definitely Ozempic, Trulicity, these are all brand only, so can be kind of expensive. And once again, sometimes hard to navigate with insurance coverage. Once again, common side effects are GI related, but that's basically what leads to the weight loss, which can be very helpful to kind of jumpstart weight loss for members or for patients. These can be used, so Wegovy is the form of semaglutide without the indication for diabetes, so it's purely just for weight loss. Very popular right now, and I know even for diabetics it can be hard to get your hands on these drugs because everyone's wanting to try them. If they are used for weight loss, I think the big thing to remember is that no drug fixes everything, right? So it's weight loss, but also eating healthy and exercise, and understanding that if you stop taking these medications, then usually the weight will come back unless you make some lifestyle changes. And this is, I think, one of the areas that we don't necessarily know the long-term side effects because they are newer medications. So we do have a lot of people kind of trying to jump on the bandwagon of the hot new drugs out there. I'm not trying to scare anyone off of them, but just be, aware that newer drugs, sometimes we don't know as much about. But from what we've seen thus far, besides the GI side effects, seem to be fairly safe and effective.
Rachel, on the Ozempic, there is a coupon for those also.
There is.
Yeah,
Yes.
and that helps with the price also.
Yes, a lot of these newer drugs will have coupons. So the SGLT2 inhibitors that I mentioned a few slides back also have coupons. Anytime you can't afford a drug, I, as silly as this sounds, encourage patients just to get on Google and type in, for example, Ozempic coupon, because that drug manufacturer is going to want patients to try their drugs, right? So they're going to incentivize you like, hey, fill this drug and we'll give it to you for $5. So what happens is the prescription usually goes through your insurance, and then the drug company picks up whatever the copay is. Sometimes they'll leave $5 for you to pay on your own. But yeah, as silly as that is, and it sounds very basic, Google is your friend. Go out there and see what resources there are. There's a lot of resources in terms of helping patients pay for drugs. And like I said, if you guys ever have problems navigating that, that is my job. That's what I'm here for. Feel free to email me and send me those problems. But yes, great point. Thank you for bringing that up. And then last but not least is a similar medication. So this is also GLP-1 agonist, but works on basically a very similar hormone called GIP. and this is Mounjaro. So this is new within the past year, and this is once again a very hot drug. So this has more weight loss benefit than Ozempic, but is really also fantastic at lowering blood glucose levels. Once again, something we probably all should have bought stock in a few years ago, I guess. But it works the same way, so decreases food intake and gastric emptying, increases insulin secretion from the pancreas. And I think of all the drugs that we've talked about thus far, probably your most A1C lowering, up to 2.3%. So pretty impressive. Same thing, it is expensive because it's brand only. I know Mounjaro I don't know who makes it, but I know that the drug manufacturer does have a coupon. I believe this one will make it $25 a month for up to a year. Nice thing is it's a weekly injection. These are tiny needles for most of these drugs because they're pens, so they're not super painful. Once again, a risk of thyroid cancer. This drug we really don't have any long-term data about because it was just released to market. Probably similar to the GLP-1 agonists with the thyroid cancer risk, potentially risk of pancreatitis, but nothing really super long-term that we know of yet. But I'm sure some things will start to come out within the next year or so. So something else you might hear of, I know a lot of patients are trying to get on it because of how effective it is. So that's it for general treatment. Like I said, I'm not gonna bore you guys around lunchtime with a whole lecture on insulin, but just to, for completeness sake, we'll briefly talk about there's different types of insulins. We have our long acting and our intermediate acting. And basically what these do is provide basal coverage, so just baseline glucose coverage. You usually either use these once or twice a day. I think the most commonly known agents here are Lantus and Levemir. Tresiba is a newer one. Semglee, which is kind of a fun name, is a generic of Lantus. Those are usually given to all patients or NPH. And then we also need some short or rapid acting insulin to help cover glucose that we ingest around mealtime. So either Novolog or Humalog or regular insulin. If you've ever had a pet that was a diabetic or just needed to buy insulin over the counter, regular is kind of our oldest, but kind of our most reliable insulin and very easy to administer, usually just 3 times daily before meals, sometimes 4 times daily if you have a big snack at bedtime. So like I said, won't go more into insulin because I know it is a whole topic within itself. Usually not used unless a type 2 diabetic has an A1C greater than 10 or used for all type 1 diabetics. Really your A1C lowering with insulin is kind of limitless. I've seen people go from an A1C of 25 to an A1C of 8 with insulin. So basically what was missing is they just didn't have any insulin. Also the most natural option, because you're really just replacing a hormone that should be in the body. So that's why we use 2 different types for patients to kind of mimic what should naturally be happening. So yeah, kind of an interesting topic. Like I said, if you have any questions or comments, feel free to email my way about insulin. Like I said, I know it can be overwhelming. Treatment of comorbidities. This is probably a good advertisement for some of John's other courses that he'll talk about Heart Smart and kind of preventing some other types of disease states. But big things that can occur in diabetic patients are, of course, cardiovascular disease, renal disease, and microvascular complications. So big things here are for all of these disease states is glucose control. For cardiovascular disease, you're also going to want to make sure that we keep an eye on cholesterol, so healthy diet, potentially some medications like statins. Aspirin is a question I always get. Should I take an aspirin? Unfortunately, I don't have a good answer for everyone. It's very dependent on kind of what your medical history is, your risk of bleeding, whether or not you're going to benefit from it. But I think if you're not taking an aspirin and you want to know, ask your doctor, should I be taking an aspirin? And they can tell you. Control of hypertension, avoiding smoking, things like that. So remember, this isn't just controlling one part of your health, it's really taking a whole picture of it and doing it all. Hypoglycemia management, I think that John goes over this, but we always teach patients the rule of 15, so 15 grams of carbs. If you like glucose tabs, they're kind of terrible tasting, but anywhere from 3 to 4 glucose tabs at a time, half a cup of regular soda. That is not a 2 liter of Mountain Dew, so it's just half a cup, or about a cup of skim milk. We tell patients then to recheck in 15 minutes. And if their glucose is still low, typically less than 70, we ask them to retreat. If you are someone super prone to hypoglycemia, you can ask your doctor for a prescription for a glucose kit, basically just an IM injection of glucose that you can either administer or a family member could give you. And then, of course, I have to give my little pharmacist speech. Of course, for everyone, we ask you guys to know your meds. You don't have to memorize it, but we do encourage all patients, bring a complete list. Honestly, have it on you at all times, but when you go to the doctor, when you go to the hospital, unfortunately in this country, we don't have great sharing of information through different institutions, even like what gets filled at a Walgreens, they don't know that at a CVS. So the only way we know is from patients telling us. Missing a dose is a question I always get. Usually do not double up. The safest thing to do is either call your doctor, but honestly, the fastest thing to do is probably call your local pharmacy and ask your pharmacist. Storage, another thing that sometimes surprises people, keep your medications not in the bathroom. Worst place, especially in Florida, to keep them. It's hot, it's humid. We encourage patients to keep them probably in a cabinet or on top of a fridge and keep them in those gold bottles they come in. They're in there for a reason. Anywhere that pets and kids can't get. And then last but not least, like I said, if you guys have any questions, comments, suggestions for things to include, my email is on there. I'm on my email more than I care to admit, so feel free to send anything my way. And with that, I am done unless you guys have any questions.
Thanks, Rachel. Yeah, if there are any questions, you can unmute yourself, type them in the chat, and we'll get those addressed for you. And also, we will send out copies of Rachel's slides and then the details as far as a link to the recording.